So tonight we are discussing endometriosis, overcoming endometriosis strategies for success. And we're going to be discussing a number of things on this webinar, but we'll talk about the physiology behind endometriosis and why it affects fertility specifically, the different types of endometriosis and how they differ in prognosis for future fertility, pros and cons of surgical treatment, benefits of medical therapy, and the role of IVF in treating endometriosis. So lots of great things to talk about. So without further ado, I will welcome John McNaught. He is the medical director at Fertility Ontario here in London, Ontario. He's extremely passionate about his career and loves helping people build their families. He does a lot of outreach through social media and the website. So if you haven't liked us on Facebook, go like us on Facebook. And he has greatly enjoyed the success of our webinar series and how many people we've been able to help. So welcome, Dr. John McNaught.
Thanks a lot, Melissa. It's really great to see so many people out again tonight. We took a bit of a break over the summer, and now the webinar series is back up again. And tonight's topic is one that people have been asking for, and I think it's because it affects so many people. Not only does endometriosis affect many patients, but it's a huge challenge for them, both emotionally, physically, and as an obstacle to building their family. What I'm really going to attempt to do today is try and explain endometriosis in the simplest terms possible. So I've taken a number of academic presentations that I've given to universities and hospitals before and tried to translate it into something that you would be able to take away and explain to somebody else. So, if the language seems a little bit simple, sometimes that's the best way to understand things, is to be able to put them into words that we can all understand. Okay, so again, strategies for success. Specifically, what we're going to be talking about is success with respect to infertility. We obviously know that endometriosis is a huge pelvic pain condition as well. However, the treatment of endometriosis as it relates to pelvic pain and as it relates to subfertility are very, very different. Because I know who my audience is, we're going to focus mostly on aspects relating to fertility therapy. So, Mel has already introduced herself, and please remember that she's here to help us. Your questions will get answered. Melissa's very good about not missing a single one. We remind you again that this is a confidential environment. No one is watching you. This is, your identity is not known to the rest of the group. Feel free to ask as many questions as you can. You'll find that when we go through something like this together, we support one another and we learn from one another, and hopefully everyone will come away with this being a little bit better than they were before. And again, and I always got to do this little legalese at the end, comments and answers to questions do not constitute specific medical advice. Okay, so we're going to talk about what endometriosis is, and most people do not properly understand what endometriosis is. Some of us apparently don't even know how to spell it. Endometriosis and how it affects fertility, that's going to be my main focus. I'd really like to drive home the whole concept of classification or staging of endometriosis. If you leave this talk learning one thing, it's that not all endometriosis is the same. We're going to talk about the role of surgery and the role of medical therapy. And finally, how those two things relate to advanced fertility therapies like IVF and other options. So, what is endometriosis? I guess the easy definition is to say that it's endometrial glands that have deposited in areas of the body other than the uterus. So endometrial glands are shed in menstrual blood every month, and they're very hormonally responsive. One of the most popular theories of the development of endometriosis is what's called retrograde menstruation, meaning that the menstrual blood is pushed back through the fallopian tubes and deposited into the pelvis. Fair enough that most endometriotic implants are found within the pelvis, but some are also found in every other area of the body. I've known people to have, a pneumothorax in their lung from endometriosis. I have a lady with endometriosis in her nose, and whenever her hormonal cycle comes around, she gets a massive nosebleed. There have been people who have had endometriosis diagnosed in the brain, and rather than a menstrual cycle, they get a seizure. So right from the get-go, the absence of a unifying theory for the development of endometriosis tells us that there's always more to be known about this baffling disease. Why does it cause so much pain? Whether the implants are in the uterus, in the pelvis, in extrauterine tissue, they always retain their receptors for ovarian hormones. And so endometriotic implants are exquisitely sensitive to the action of ovarian hormones. That's why one of the classic signs of endometriosis is pain with menstruation. And that's often how it presents for the first time in young women. We find as the estrogen levels drop as menstruation approaches, the implants will constrict, and their constriction will trigger an intense inflammatory response. Over time, the nerves in the pelvis will become chronically excited, and you can develop a chronic pain syndrome on the basis of endometriosis. The inflammatory mediators that are generated can also be found in the pelvis and can lead to the development of further endometriotic implants beyond the uterus. I think in a real world scenario, most of you know what this is like. If anyone has been doubled over on the bathroom floor, on the verge of vomiting, unable to go to work, checking into the emergency room because of pelvic pain, there's a high probability that you are suffering symptoms of endometriosis. There are other pelvic pain conditions that cause a similar set of symptoms, but the classic one that knocks people off their feet is endo. And the surprising thing about pain in endometriosis is the amount of pain that you have doesn't correlate very well at all to the amount of endometriosis that you have. You can have very, very minimal deposits of endometriosis within the pelvis and still have enough pelvic pain generated to put you into the emergency room. So the perception of pain is very much individual. What someone is going through doesn't tell us a whole lot about how much endometriosis might actually be present. With respect to the effect of endometriosis on fertility, I guess my response would be identify any step that is important towards making a baby, and endometriosis has a negative impact on that step. So endo can invade the tissue of the ovary and destroy healthy ovarian tissue. It can destroy ovarian reserve on that basis. Egg quality is diminished by constant inflammation. Ovulation is sometimes infrequent. The transport of the egg through the fallopian tube is inhibited by the intense inflammation associated with endometriosis. Fertilization is less likely to occur in a natural setting, and implantation is less likely to occur in patients who have endometriosis. Early on in the diagnosis and classification of endometriosis, I think we were looking for a magic bullet. Fix this one thing, and perhaps you could overcome the association between endometriosis and infertility. The more modern interpretation of the problem is that it's global. It affects the entire pelvis, ovaries, fallopian tubes, uterus. If you don't take a global approach to the treatment of endometriosis, you are more than likely to fail. So how many people might have endometriosis? You may very well be one of those people who has been diagnosed with what we call idiopathic infertility. Idiopathic infertility means that we recognize you as being infertile, but we don't know why. In studies where we perform laparoscopies on patients who identify themselves as being infertile, as many as 50% of those who undergo laparoscopy will have some degree of endometriosis. And I always say I don't believe in idiopathic infertility. Practically, we can't perform a laparoscope on every single patient who comes through a fertility clinic. So we do have to go through a screening process of sorts. But if there's a future tool that we need for endometriosis, it is the ability to diagnose it without having to have someone undergo a surgical procedure. Because at that point, we might really start winning. So how is it diagnosed? Well, more and more, I am able to see it by ultrasound. There are certain collections of it that are so classic that I'm confident to point at it and say, yep, that's an endometrioma. The problem is that an endometrioma is a fairly advanced form of endometriosis. And as a professor of mine used to say, at that point, the horse is out of the barn. What we need is a less invasive way to detect the disease in its early state so that we can modify it, induce a submission of sort. To date, there hasn't been tremendous progress in that area. We do have some blood markers available for general inflammation, such as a CA-125 level, but they are wildly nonspecific, and they tend to be expressed more often in severe disease. So the search for a screening tool for early endometriosis will continue. Until then, the gold standard for diagnosis remains this camera-based procedure that we call laparoscopy. When we go to laparoscopy, we're able to classify the endometriosis by 4 different stages. Now, there have been some newer classifications systems trotted out in the last 5 years. I still use the old-fashioned one because I think it still has the same clinical significance and it's easier for patients to understand. So I still use the ASRM classification, American Society of Reproductive Medicine. And what we see there is that there are 4 different stages of endometriosis, and they're each associated with a different prognosis with respect to fertility. And again, this would be one of the key take-home points from tonight. If you have endometriosis, you need to know what stage you are. You can't really help yourself if you don't understand the nature of your disease. So, and I apologize if the next few slides are a little graphic for anybody. Most of them are interior images taken from operative laparoscopy. It's basically endometriosis in the pelvis. I don't think it will offend anybody, but if it does, I apologize. This is minimal endometriosis. So what you see here is just a really, injected erythematous scattering of endometrial tissue on what is otherwise healthy lining of the pelvis. And this doesn't look very big and bad, but this is actually associated with a high degree of pain. Kind of the puzzle of endometriosis is that these smaller lesions will actually induce a much stronger inflammatory component. So even though this patient has a minimal amount of endometriosis, the potential exists that she might be in excruciating pain. This is stage 2 endometriosis. It is considered mild, and it consists of superficial implants that are less than 5 centimeters total, scattered on the peritoneum and sometimes the ovaries. And the key is that there is no significant adhesions present. I look at this, and this is fairly significant endometriosis. This surgeon has classified it as stage 2, but already you see that you have webbing of structures to other structures. You have fairly significant adhesions. There is lots of erythema and injection. There's a fairly diffuse amount of disease there. This is fairly serious endo, and I'm not sure if I was the surgeon operating, even with a laser, that I could confidently say that I vaporized all of the endometriosis that was there. In a case like this, you're almost always going to leave behind some macroscopic endometriosis. So this is, pardon me. This is stage 3 endometriosis, and as you can see, as we go from stage to stage, the pictures get a little bit uglier. This is moderate disease, and it exhibits multiple implants that are both superficial and invasive, meaning that they're actually digging in to the lining of the pelvis and digging into the ovary itself. You see that the fallopian tubes are involved, and there are adhesions to the ovaries themselves. At this point, you have traversed from the minimal and mild disease into something that has a very serious impairment on fertility. There is a tremendous danger in a case like this being misdiagnosed as minimal to mild endometriosis. There's a lot of impairment here, and even if it gets cleaned up, you have to understand that there is an intense microscopic inflammatory process that impairs a woman's fertility. And if you don't treat that and identify it, you can't help that person. This is also stage 3 endometriosis. You see how this pelvis here looks a lot nicer and cleaner than the previous one? The only thing that we do see here is this very large collection of endometriosis called an endometrioma. And a lot of surgeons will just pop open that cyst, maybe take the roof off of it, and the rest of the pelvis will look relatively clean, and they'll leave things alone. I consider any endometrioma to be stage 3 disease, because for my purpose, I use the staging to try and prognosticate as to someone's potential for future fertility. If you break open that cyst and drain it, not only is it very likely to reform, but in many cases you'll see that that a seeding of the endometrial glands throughout the rest of the pelvis, such that if you came back and did another laparoscopy 6 months hence, the patient's pelvis would be covered in endometriotic implants, and it's because of the endometrial glands that are contained within this mass. So although it looks quite a bit cleaner, this is also very significant disease. And finally, this is stage 4 endometriosis. Basically, at this point, everything is stuck to everything else. You have superficial and deep implants, very large endometriomas, all kinds of adhesions from one organ system to another, just an absolute mess. And at this point, the probability of pregnancy spontaneously approaches 0. So if you have that much disease within the pelvis, unless you get some serious medical help, your chance of achieving pregnancy spontaneously is very, very small.
John, I've got a question here. Actually, I have a lot of questions. So
sure. Yep.
I've been looking for the perfect moment to just jump in here.
That was it. That was the one.
Perfect. Awesome. One of the questions here, and I'm not going in, I'm kind of just trying to organize the questions here. How are people going to know what stage they're at? Because you noted that sometimes people may be diagnosed as, mild when they might have moderates. So I guess, if people are at this stage where they kind of know they have endometriosis, but they're not sure what stage they're in, how do they go about figuring that out?
Well, obviously, you need to, in most cases, you need to have a laparoscopy. If you have the presence of an endometrioma on ultrasound, I'm going to argue that you're at least a stage 3. In order to get properly staged, you do need to have a laparoscopy performed. And when you do that, you want to have your surgery done by someone who understands the association between endometriosis and infertility. What a lot of people will do is make a copy of the ASRM guidelines for staging and hand them to their surgeon preoperatively and ask them to fill it out. And that's often a reminder to their surgeon that if they have endometriosis, the stage of endometriosis is important to them.
Good tip. We have a question here. This is actually a great question. So this is from Heather. Heather's asking, why do so many women have endometriosis? Why is it so common?
We don't really know. It's not something that I see decreasing in frequency over time. The size of uteri over time are getting bigger because human offspring are getting bigger. So the menstrual muscle and their accompanying glands are going to be exaggerated in size. There does seem to be some sort of an immune component to endometriosis, where people who suffer from endometriosis seem to be at higher risk of other autoimmune problems. So over time, that's something that could propagate itself. Artificial hormone use is probably not going to help the problem. Who are we kidding? Pregnancy is the natural predator of endometriosis. The high levels of progesterone that we see in a term pregnancy can be as close to curative as you're going to get for the condition that is endometriosis. So people who are continually delaying their childbearing or suffering from subfertility, those two phenomena, which we see quite prevalent in our society, are things that are going to only cause an increase in the incidence of endometriosis.
Interesting. We have kind of a case scenario here, and I think this kind of fits into the last question because there seems to be this air of confusion around endometriosis. This question's from Cheryl, and she says that her gyno refuses to do a laparoscope. I'm not saying that right tonight because 8:30. My apologies. So basically, her
laparoscopy.
Thank you. I'm not going to be able to say it tonight. Basically, her GP is, just medicating her and sending her on her way, and really not giving her a referral to another gyno. What's something that she can do, as she has something called flare-ups that basically have her in the hospital for days at a time?
Wow. If you're in the hospital, if you're hospitalized with pelvic pain, you should be seeing a specialist. That's something that I think is fairly obvious. The pelvic pain may not be endometriosis, but it's the treatment of pelvic pain. We have so many options available these days that a lot of people are not aware of what the full armamentarium is. Depending on what area of Ontario you live in, I do accept self-referrals for fertility patients. Currently, I don't accept self-referrals for pelvic pain patients, but I would be willing to make an exception if you live close to London, Ontario. I could certainly at least have a look at your case and give you some advice.
Thanks for that. We have lots of questions here. This is a really good one. Is there any evidence that endometriosis is hereditary?
It's so prevalent that it's hard to prove that it's hereditary, but I certainly know several mother-daughter pairs and sister pairs who have endometriosis. The autoimmune aspect of it has a genetic component to it. The size and shape of the uterus tends to that tends to have a familial association with it, as well as the onset of menstruation. That often will follow closely in mother-daughter pairs. So I would, the answer is yes. There does seem to be some familial association. I couldn't quote you hard numbers, but we see it so often that it's just one of those accepted proofs.
All right. So this is actually a really good question. Does your stage of endometriosis change over time? So if you are treated laparoscopically, there it is, and have a successful pregnancy, will you still be at the same stage as before the surgery?
Can you downgrade in stage?
Hmm.
You can, particularly if you become pregnant. There are not too many medical therapies that can downgrade the stage of endometriosis that you have, but there is nothing for endometriosis like pregnancy. So we have seen people after a term pregnancy who never have symptoms again. We've seen people with severe disease post-pregnancy who have mild minimal disease if they have a second laparoscopy. So it's not curable, but it is relatively plastic. The only thing that is going to make a significant difference in terms of severe disease being downgraded would be something like pregnancy. The other aspect of it is if you're stage 4, Stage 4 usually tends to cause some mechanical scarring. So irrespective of the hormonal activity of the endometriosis, the scarring tends to be a lifelong thing.
Here's a really interesting question that I was wondering earlier. If you are able to conceive, because we just talked about how that's a really great option. If you're able to conceive, can this disease affect the baby while it's developing, or are you at greater risk for miscarriage?
No, the risk of miscarriage is not that much higher than on average. People have tried to attribute a higher rate of miscarriage to endometriosis, and realistically, that doesn't trend out as strong data. If you look at the risks of miscarriage, it being at 20 to 25% depending on how old you are, it's really hard to prove that a common miscarriage was associated with endometriosis. Um, Generally, the issue is around implantation. Once you have successful implantation, you are as close to a normal pregnancy as any other person.
Alrighty. Um, Sarah, this question is one that you just asked. Sarah had a lapros. Oh, I'm not going to say it. I'm just going to say lap because that's what she typed. LAP, May 2012, with minor endometriosis, mostly near her bladder. Her RE did the surgery and minimal. Her RE did the surgery and minimal invasively, very rare and very small incisions. Sorry about that. I I then needed a special stitch due to cervix issue during the surgery. They found extensive adhesions within 9 months of the initial surgery. Um, is there a correlation that the adhesions are related to endo as opposed to the surgery? Sorry if that sounded a little bit scattered.
Yeah, that's hard to, you know, anytime you do any type of laparoscopic surgery, the possibility of having adhesions after a surgery is there. Um, so it's very difficult to say one way or the other how those adhesions are caused. It's one of the reasons that you want to try and operate as little as possible, because even though cosmetically from the outside the incisions look small, there's still a tremendous amount of surgery that is done on the inside. Now, if that surgery is done for a good purpose, then we can accept those as surgical risks. But you need to have a very clear rationale of why you're putting that camera inside somebody's belly, because anytime you are looking for surgical benefit, it's always going to be dovetailed with surgical risk. And even the minor stuff like adhesions, that doesn't seem like a big deal at the time, but a lot of people will have a lot of abdominal discomfort and bowel dysfunction on the basis of adhesions from laparoscopy.
Awesome. This question is not a kind of another specific question, and it's for Leah. Um, Leah has been diagnosed with stage 4 endo and has had two lapros. I'm not going to say that right. This is just one word I'm just not getting tonight. Um, ah, geez, and a laparotomy.
Laparoscopy.
Lap. Can you say that one more time?
Laparoscopy.
Laparoscopy. It's just, I don't
Laparoscopy.
know what it is. It's just one of those words for me. Um, so she's had two of those and a laparotomy in the last 3 years and has been dealing with an ovarian cyst for the last 8 months. So her question is, do you think another cleanup, a surgery, is beneficial before considering something like IVF to ensure that it's successful?
The cleanup.
Hmm.
That comes up quite a bit. Um, I am generally against the cleanup because I don't, and we'll get into this down the road, but um, if the cleanup is to remove as much endometriosis as possible, then I don't think it's worthwhile. If the scarring from endometriosis has moved the ovary away from a point where we can access it for IVF, then yeah, there is some merit to having further surgery. I'll give you the example of I have a patient who we put her through an IVF cycle. She does have severe endometriosis. And when we went to retrieve the left ovary, endometriosis had scarred it so high in her pelvis that we weren't able to retrieve it. So we lost about half the number of eggs that we were hoping to get. And we sent that patient back to one of our surgeons and said, you know, we realized that this may not be possible, but can you do your best to put this lady's ovaries back to where they used to be? And, you know, that's not going to help her become pregnant, but it's going to help us help her become pregnant.
Got it. That was a really good question. Um, this same question is also from Leah. So she just wants to clarify. You noted that someone who has endo, um, or was it? Sorry, I'm just going through this. You noted earlier that if you have stage 4, that you have a very low chance of pregnancy, and I think that was kind of shocking for one of our attendees here. Uh, is there any data about that, or is it kind of just a grim reality? I think that shocked a
Oh,
few people.
that's a segue into my next slide.
Okay, maybe that's a perfect opportunity to segue.
Okay, I'm gonna segue very quickly, and then we will continue answering questions.
Perfect.
So the reason that I'm so obsessed with staging is because it is so important with respect to both prognosis and treatment. And so I want you to consider a study from the 1980s, which we probably wouldn't be able to do anymore because we wouldn't get past our ethics committee. But all they did for 25 months was watch patients with endometriosis. So they knew how bad their endometriosis was on the basis of laparoscopy. And he saw that the effect of fecundity, or the chance of pregnancy in a given month, seemed to be worse based on the severity of endometriosis, as observed expectantly over 25 months. So that's over 2 years. So in people with mild disease, he saw that their fecundity was about 5.7%. But overall, over those 2 years, most of them would get pregnant. And that's kind of typical of what we see with mild disease, is that the pregnancy rate is less, because normal human fecundity is about 20%. But you know, if you give them time, those people will get pregnant. When people had moderate disease, so that's your sort of stage 3, he saw pretty low fecundity of only about 3.2%. In over 2 years, only 25% of them became pregnant. And the most shocking finding in Dr. Olive's observation over those 25 months is that when somebody had endometriosis, over 2 years and a bit, not a single patient got pregnant naturally. Questions?
Yes, we have lots of questions. Um, that's, let me just find a question here that relates to kind of what you were just saying here. Let me go down a little bit more. All right. This question here. This is the webinar where we've had the most amount of questions, I think, ever. So this is fantastic. Um, this question is from Ashley, and it's another kind of specific question about her circumstance. So she's had an LIP surgery and then was put on Lupron, which helps with inflammation. She was started with an endometrioma. All these words are just killing me here. Just kidding. On my ovary, and now is not present on any ultrasounds. So her question is that she's currently going through IV. She's currently also going through an IVF process. What is the likelihood of her egg quality being poor? And will the embryo still have trouble implanting due to her condition?
Um, I'm going to pass on that one because I'm going to talk about that a little bit more down the line.
Perfect.
Remind me to answer that question.
Okay, I will do
I
that.
obviously have an answer, but I don't want to give too much of the back half of my presentation away.
Well, let's do this because we have a number of questions here, and I think some of them might relate to your slides coming up. So let's go through those, and then I'll just kind of organize the questions here, and we'll kind of tackle them in the next break.
Yeah, okay.
Okay.
Yeah, I won't kid you. Things will get a little bit controversial going forward because most of my opinions on endometriosis are my opinions on endometriosis, and they're certainly not shared by every single person who treats either infertility or endometriosis. So let's talk a little bit about surgery. On the left there is someone having a laser laparoscopic surgery to identify some of those spots of endometriosis that we looked at earlier. And there is a camera as well as with a laser attached to the end of the camera that would allow us to vaporize the endometriosis if we could see it. And on the basis of a very famous Canadian study, this is again a study that wouldn't make it past ethics these days, but they did laparoscopies on hundreds of women, and if they had endometriosis, they were randomized to either doing nothing, i.e. they didn't treat the endometriosis even though that it was there, or they vaporized it. And they showed that when it was minimal and mild, the vaporization of the endometriotic implants actually caused an increase in the pregnancy rate. That's a study that we can never repeat again because the ethical implications of doing a sham laparoscopy on patients wouldn't be very well received. But it's medical history, and it's something that has created the notion that if you have endometriosis and you want to get pregnant, what you need is laparoscopic surgery. Now that's true if you have early endometriosis. It's really not true if you have advanced endometriosis. Wow, my spelling tonight is just atrocious. So when you have that stage 3 and stage 4 endometriosis, laparoscopic surgery alone is not necessarily the answer. In terms of, sole therapy or pre-treatment of IVF, there's very little evidence that shows a benefit to laparoscopic treatment for severe disease. Now, there are a lot of studies that show that there's no benefit, and there are some additional studies that show there may be a detriment because it's very difficult to operate in and around the ovary without actually damaging some healthy ovarian tissue. So you need at least one good laparoscopy for endometriosis in order to vaporize what you can and properly stage the disease. There may be a role for that second laparoscopy, the kind of the cleanup or debulking that people talk about. But really and truly, I don't feel there's a role for repetitive laparoscopy in the treatment of endometriosis. And unfortunately, that's something I still see quite a bit of. So once you've had a staging laparoscopy, repeat surgery doesn't necessarily improve your outcomes. And as I said, some studies show a drop in ovarian reserve after repetitive laparoscopic surgery. So if we can't do surgery, what do we got? Well, the main cornerstone of management is medical, 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 medical. So once you've used your surgery to tell you what you got, and maybe, vaporize as much of it as you can see, the only appropriate next step for what is ultimately a microscopic disease is medical therapy. You can think of it kind of like cancer, You can go in with a huge surgery and you can excise as much cancer as you can see. But if you want to do the patient a favor, they're probably going to get some form of chemotherapy afterwards, because that's the only way that you're going to know that you got everything. And endometriosis follows a very similar model. So once surgery has occurred, the medical suppression of endometriosis becomes the mainstay of both pain and fertility. The main medication that we use for severe endometriosis is called Lupron. It's a GnRH agonist that's taken for 3 to 6 months at a time, and it suppresses even microscopic endometriosis by inducing very low estrogen levels. I know some of you probably have some questions about the side effects of Lupron, and I promise I will get to those. As an alternative to Lupron, sometimes for people who can't take Lupron for whatever reason, there's now an oral medication available in Canada called Vizan. It's a potent progestin, and it's often taken for about 6 to 12 months at a time. When studied head-to-head against Lupron, it's as effective at relieving pain associated with endometriosis. The next step with Vizan is to see if it works as well as a pre-treatment for fertility therapy. And to date, we don't have that information. So what about fertility therapy? You know you have endometriosis. What are your choices? What should you do? I think the thing that people don't do often enough is call it what it is. You have to understand that the efficacy of all fertility treatments is decreased if you have moderate to severe endometriosis. People will often say, well, if you have endometriosis, you should do IUI. I can't say that no one has never achieved pregnancy using IUI with severe endometriosis. But if I told you that the rates were in the 3 to 5% range, would that be acceptable? That's not a very high pregnancy rate at all. Realistically, if you want to have real success with severe endometriosis, the gold standard is IVF. And this is one of the reasons that we push the government so hard to treat infertility as a medical condition, is that endometriosis is a medical condition that causes infertility, that leaves a woman with about as much chance of becoming pregnant naturally as if her fallopian tubes were blocked. We look back to Dr. Olive's observations from 1985. In his patients with severe endo, none of them became pregnant spontaneously. I have more patients who have so-called blocked fallopian tubes who become pregnant spontaneously than stage 4 endo patients have. It indicates the need for IVF as a medical treatment for a medically indicated illness. When they previously examined the early use of IVF in treating severe endometriosis, they compared it to tubal factor infertility. And they thought, the tubal factor infertility patients were relatively good prognosis. What they found was that patients with severe endometriosis did very poorly in IVF. If the tubal factor had a pregnancy rate of 30%, the common pregnancy rate in severe endometriosis was 10%. And we struggled for a long time to try and increase the outcomes in IVF, either through repeat surgery or debulking, until ultimately it was discovered that medical treatment prior to IVF held the key in terms of outcomes. So going back to Lupron, and we should spend some time talking about this, patients who have had Lupron will have 4 times the chance of successful pregnancy in IVF if they're given Lupron for at least 3 months prior to IVF. And that's why currently, my standard is if you have severe endometriosis, you're getting Lupron before IVF.